So in yesterday lecture, we discussed the causes of jaundice in the first 24 hours and the causes of prolonged jaundice. Some of the causes of prolonged jaundice included biliary atresia, which is a cause of conjugated hyperbilirubinemia, breast milk jaundice, and galactosemia, which are causes of unconjugated hyperbilirubinemia. Other causes that we discussed in the hematology chapter, they include G6PD deficiency and sickle cell anemia. Congenital hypothyroidism, we discussed it in endocrinology chapter. So jaundice with features of hypothyroidism, our diagnosis will be congenital hypothyroidism. So a baby who was born, a baby who developed jaundice within 24 hours after birth, he should be advised to return to the hospital to be seen within 2 hours. So according to NICE guidelines, if someone develops jaundice within 24 hours of his or her life, then he should be advised to return to the hospital to be seen within 2 hours. Now, a child with chronic cough plus jaundice. Jaundice with chronic cough, the diagnosis will be alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is basically protects the body tissues against the proteases. The damage that is caused by proteases, alpha-1 antitrypsin is a protecting factor against proteases. So when there is deficiency of alpha-1 antitrypsin, proteins will be damaged in the lungs and in the liver. So the damage in the lungs will lead to chronic cough, and damage in the liver will lead to jaundice. So if a child presents to us with chronic cough and jaundice, then our diagnosis will be alpha-1 antitrypsin deficiency. We have discussed yesterday that breast milk jaundice is a cause of unconjugated or indirect bilirubinemia. And the difference between galactosemia and breast milk jaundice is that in breast milk jaundice, the infants are well and they are feeding normally, and there is no vomiting or diarrhea. So we are done with the causes of jaundice. Now we'll do some causes, other gastrointestinal disorder. And the first of them is pyloric stenosis. So now we are going to discuss some causes of vomiting in children or in infants. Vomiting and bleeding per rectum. Some causes of vomiting and bleeding per rectum. Now the first of them is pyloric stenosis. What is pyloric stenosis? Pyloric stenosis is when the pylorus of the stomach becomes stenosed. It is thought that babies who develop pyloric stenosis are not born with it, but have progressive thickening of the pylorus after birth. So the babies are usually not born with pyloric stenosis. They develop progressive thickening of the pylorus after birth. So a patient with pyloric stenosis will present weeks after birth and not immediately after birth. So remember this presenting time for pyloric stenosis. Now, because the pylorus of the stomach is thickened, so the food content will not pass from stomach to the duodenum. So the baby will develop persistent non-bilious vomiting. Remember that bile is brought by common bile duct, which opens into the second part of the duodenum. So if someone develop obstruction beyond the second part of the duodenum, he will develop bilious vomiting. And if the obstruction is proximal to the second part of the duodenum, then the vomiting will be non-bilious vomiting. So the baby will present to you with persistent non-bilious vomiting, usually an hour or 30 minutes after feeding. Because there is no issue in the stomach, so the baby will develop vomiting 30 minutes or after an hour after feeding. So remember these 2 points, that pyloric stenosis presents at 4th or 5th week of life with persistent non-bilious vomiting that occurs 30 minutes or after an hour after feeding. The baby usually feel constant hunger. There is weight loss and dehydration due to vomiting. Now, in the clinical features, 2 features are important to remember. One is that vomiting, persistent non-bilious vomiting, or the patient present to you at 4th or 5th week of life, and vomiting usually occur 30 minutes to hour after feeding. Now, the third hint for pyloric stenosis is that there will be an olive-shaped mass in the abdomen, and due to vomiting, electrolyte abnormalities and vomiting of the gastric acid will result in metabolic alkalosis. So loss of potassium in the vomiting will result in hypokalemia, and loss of acid in the vomiting will result in metabolic alkalosis. So 3 points are important to remember, and that are uh, pyloric stenosis presents at 4th or 5th week of life, and vomiting occurs 30 minutes to an hour after feeding, and the child is constantly hungry, and there is weight loss and dehydration. And the third point is that there is an olive-shaped mass in the abdomen. The complication of pyloric stenosis, they include electrolyte abnormalities and metabolic alkalosis. So if a scenario is given regarding pyloric stenosis and they ask you about the most urgent investigation or the most appropriate initial investigation, then your answer should be serum potassium level. And the diagnosis is confirmed on ultrasound. So the definitive diagnosis is made on ultrasound, and the treatment is very simple: fluid replacement and correction of electrolyte imbalance. So initially we'll replace the fluid and electrolytes, and the definitive treatment is pyloromyotomy. That is making an opening in the stenosed pylorus. This procedure is known as pyloromyotomy. So a summary of pyloric stenosis include projectile, non-bilious vomiting, 30-minute or an hour after a feed in a 3 to 8 weeks neonate. And the second hint is that there is a palpable olive-shaped or almond-sized mass on the upper abdomen. Hypokalemic and hypochloremic alkalosis, metabolic alkalosis due to loss of stomach acid, a hungry baby who wants to feed regardless of the constant vomiting. So though there is constant vomiting, regardless, the baby still want to feed because he is constantly hungry. The diagnosis is confirmed on abdominal ultrasound, which will show a thickened pylorus. Remember that repetitive projectile non-bilious vomiting, especially after feeding, 30 minutes to an hour after feeding, is pyloric stenosis, and it can cause hypokalemic alkalosis. So if the question asks about the next step or the most urgent step, then answer would be measure serum potassium. And if the question asks about the investigation for diagnostic or the most important investigation, then abdominal ultrasound should be your answer. So this was all about pyloric stenosis. Now the next topic is duodenal atresia. Duodenal atresia is when there is obstruction or atresia of the portion of the duodenum. Again, if the obstruction is beyond the level of opening of common bile duct, then the patient will present to you with bilious vomiting. And if it's proximal to the opening of common bile duct, the baby will present with non-bilious vomiting. So persistent bilious or non-bilious vomiting and abdominal distension, double bubble sign on abdominal X-ray, your diagnosis duodenal atresia. This is a double bubble sign on one bubble is this one and one bubble is this one. So a child with persistent bilious or non-bilious vomiting and double bubble sign on abdominal X-ray or with a history of Down syndrome, then your diagnosis should be duodenal atresia. The treatment is abdominal decompression using an NG tube, fluid replacement, and electrolyte monitoring, and duodenostomy. Duodenostomy means making a hole in the duodenum. What is esophageal atresia? Esophageal atresia is it is early recognized before or soon after birth, as any attempt at feeding could cause aspiration pneumonia. Esophageal atresia is usually associated with tracheoesophageal fistula and polyhydramnios. Many may present with choking and cyanotic spell following aspiration. It is associated with vectoral defect, that is vertebral, anal, cardiac, tracheoesophageal, renal, and kidney and limb defects. So esophageal atresia is usually associated with other vectoral anomalies such as vertebral defect, anal defect, cardiac defect, and tracheoesophageal defect, and limb defect, etc. So esophageal atresia and tracheoesophageal fistula. What is atresia? Atresia means esophagus ends blindly. And what is tracheoesophageal fistula? There is an abnormal communication between trachea and esophagus. Remember that duodenal atresia and esophageal atresia, they can present with polyhydramnios during pregnancy because the swallowing of amniotic fluid will be impaired due to esophageal or duodenal atresia. So they can present with polyhydramnios during pregnancy, and there will be difficulty in feeding following birth and associated with other vector anomalies. Here's the example of esophageal atresia, that esophagus ending blindly. Now esophageal atresia with tracheoesophageal fistula, you can see that this is atresia and there is a communication between the distal portion of the esophagus and trachea. Now sometimes this the proximal end of the esophagus it opens into the trachea. So it can be atresia only. It can be a disease will form a trachea and atresia fistula. You can see that in this diagram, and comparing this diagram to this diagram, you can see in duodenal atresia there is bubble line, while in esophageal atresia there is no bubble visible on X-ray. So this is the difference between esophageal atresia and duodenal atresia. This is a point on the basis of which you can differentiate between duodenal atresia and esophageal atresia. So if no gastric bubble, our diagnosis would be esophageal atresia. A single bubble, our diagnosis would be gastric atresia. Double bubble, duodenal atresia, malrotation and volvulus, and triple bubble, jejunal atresia. So we are done with 3 causes of vomiting in children. And the first of them was pyloric stenosis, then duodenal atresia, then esophageal atresia, now intussusception. What is intussusception? Intussusception is when one portion of the intestine, for example, this one, when
What
one
is
portion of the
the
intestine,
treatment? What is the treatment of
what?
esophageal atresia?
The treatment of esophageal atresia, of duodenal atresia, and for pyloric stenosis, all of them is surgery. Surgical
Right.
correction of this atresia is the treatment for definitive treatment for esophageal atresia.
Right.
So intussusception is invagination of one portion, invagination or telescoping of one portion of intestine into another portion of intestine. In invagination or telescope of one segment of the bowel into the other segment of the bowel. How a child with intussusception will present to you? Acute colicky abdominal pain in an infant. Patient may draw knees to the chest for relief. So abdominal pain is a main presenting complaint. We saw in the pyloric stenosis that the main complaint was vomiting 30 minutes after a feed. Abdominal obstruction and bilious vomiting, red and currant jelly stools. So these are the hints for that colicky abdominal pain that is associated with bilious vomiting and red currant jelly stools. And there's a palpable sausage-shaped mass in the abdomen. So almond-sized or olive-shaped mass in the abdomen, your diagnosis will be pyloric stenosis. Sausage-shaped mass in the abdomen, your diagnosis will be intussusception. Other symptoms of intussusception is abdominal pain with bilious vomiting and red or currant jelly stools. Abdominal X-ray will show dilated gas-filled abdomen with multiple air fluid levels, and ultrasound of the abdomen will show donut sign and target sign. You can see this donut sign or target sign on ultrasound of the abdomen. Abdominal ultrasound in case of intussusception will show a donut or target sign. So first of all, we'll remember the clinical presentation of intussusception, and that is, it is common below 2 years of age. So a child 6 to 24 months old who present with paroxysmal abdominal colicky abdominal pain plus red currant jelly stools plus bilious vomiting, and there is a on initiation there is a sausage shaped mass in the right upper quadrant, and abdominal ultrasound will show target sign or donut sign. Then our diagnosis will be intussusception. The treatment for intussusception, the first line treatment is mechanical reduction, that is reduction by air enema or insufflation. And the second, if air enema is not mentioned in the question, then barium enema can also be used to correct the intussusception. And if these methods fail, then we are going to do surgical reduction through laparotomy. The first line treatment is mechanical reduction through air enema or barium enema. And if this fails, then there will be surgical reduction will be done. Our next topic is Meckel's diverticulum. So intussusception, there was abdominal pain and red or current jelly stools and bilious vomiting. Now, what is Meckel's diverticulum? Remember the rule of two. Meckel's diverticulum is present in 2 years old child, 2 inches long. It is 2 inches long and 2 feet away from ileocecal wall. The presentation of Meckel's diverticulum is painless rectal bleeding. In intussusception, there was painful rectal bleeding. Abdominal pain with red or current jelly stools was present in intussusception. While in case of Meckel's diverticulum, the only symptoms is painless rectal bleeding. And if this Meckel diverticulum is obstructed, then the person can develop vomiting and abdominal pain. The more common presentation is painless rectal bleeding. Investigation is initially radioisotope scan and laparotomy. And the treatment is symptomatic patients, patient with complications will be treated surgically. What are the complications of Meckel's diverticulum? Diverticulum can develop inflammation that is known as diverticulitis. Diverticulitis can lead to hemorrhage and intestinal obstruction as well. So whenever you see painless rectal bleeding in a 2 to 3-year-old male child, you will suspect Meckel's diverticulum. Meckel's diverticulum is basically an outpouching or bulge in the lower part of small intestine. Meckel's diverticulum is the most common congenital defect of the gastrointestinal tract. Again, painless rectal bleeding in a male child aged 2 to 3 years. The diagnosis will be Meckel's diverticulum. Initial modality or additional investigation is radioisotope scan, and definitive is laparotomy, and surgical resection is the treatment. So a neonate presents with acute onset of green bilious vomiting and blood per rectum. What is the most likely diagnosis? So the diagnosis here is malrotation or volvulus. Sudden onset of green and bilious vomiting in a neonate, and that is associated with bleeding per rectum and a double bubble sign on X-ray. So a double bubble sign is present in duodenal atresia as malrotation and volvulus. The diagnosis is confirmed on abdominal X-ray and barium enema, and the treatment is NG tube decompression and refer to pediatric surgery for laparotomy and resection. So sudden onset of green bilious vomiting plus blood per rectum, double bubble sign on X-ray. Our diagnosis will be malrotation and volvulus. The diagnosis will be confirmed on abdominal X-ray and barium enema. Now let's compare it with duodenal atresia, because both of them have a double bubble sign on X-ray. Duodenal atresia as well as malrotation and volvulus, both of them have a double bubble sign on chest X-ray. You can see in this table that double bubble sign is present in duodenal atresia as well as malrotation and volvulus. Both of them can present with bilious vomiting. So then how you are going to differentiate between these on the basis of clinical signs and symptoms. So here you can see that in duodenal atresia, the vomiting can be bilious, and it is associated with Down syndrome. In malrotation or volvulus, you can see that along with vomiting, green bilious vomiting that is sudden in onset, blood per rectum is also a feature. Blood per rectum is not a feature of duodenal atresia. So this point will help you in differentiating between these two conditions. So this was all about some causes of vomiting in children. Pyloric stenosis, duodenal atresia, esophageal atresia, intussusception, and malrotation or volvulus.
So is Meckel's diverticulum and malrotation volvulus, are they both the same?
No, they are not the same. Meckel's diverticulum is basically persistence of a wetline duct. It is basically, you can say, an outpouching of small intestine.
Right.
While in malrotation and volvulus, the gut is rotated or twisted, which
Right.
leads to intestinal obstruction. That's why the person will develop bilious and green vomiting and blood per rectum. While because Meckel's diverticulum is just an outpouching or bulge in the lower part of the small intestine. So the only presenting feature of Meckel's diverticulum is bleeding per rectum, and it is painless. There is no pain in bleeding per rectum in case of Meckel's diverticulum, because we have discussed this in gastroenterology, that a diverticulum can get infected, resulting in diverticulitis, and this
Right.
diverticulitis then can bleed.
Yeah.
So most of the time, a person with the Meckel's diverticulum is asymptomatic.
Right.
So mostly Meckel's diverticulum is asymptomatic because it's simple outpouching of the small intestine. But if the person developed diverticulitis, then it can lead to painless rectal bleeding. And
Right.
if the diverticulitis is perforated, it can lead to intestinal obstruction. So these can be complication of Meckel's diverticulum.
Right. Okay. Thank you.
Any more questions up till now?